My title today, as already indicated, is Hyperinsulinemic Hyperandrogenism, using PCO as the specific paradigm. The history of this condition, at least the recorded history of this condition, dates back to 1921, at which time two French physicians, Achard and Thiers, described a seemingly bizarre association between glycolytic insufficiency, which is the term used at the time to describe carbohydrate intolerance, in the context of virilization or in the context of a diabetic woman with a beard. At the time, at least, that seemed rather implausible, and no obvious connection between these two seemingly unrelated circumstances could be established. But over the years, there have been an increasing number of reports which have confirmed this association. And certainly since the early 80s and throughout the 90s, there is significant interest in the connection between carbohydrate economy and polycystic ovary syndrome, and in general, hyperandrogenism, hirsutism, and the consequences thereof. Some have dubbed this combination the Hyper-An syndrome, which stands for hyperandrogenism, insulin resistance, and acanthosis nigricans, which is a common corollary skin pathology, which we will discuss in just a minute. We prefer the more simple term, or relatively more simple term, of hyperinsulinemic hyperandrogenism, which is the term I will be using throughout my presentation today. A case in point is the individual shown here, a woman who was about 22 years of age when presenting to us at the University of Maryland now approximately 12 years ago. This individual of South American extraction was known since a very young age to suffer from an extreme form of insulin resistance, which required the administration of thousands of units of crystalline zinc insulin per day, which in itself merely sufficed to maintain her in a relatively fragile state of euglycemia, often punctuated by admissions for ketoacidosis. You may be able to tell that this individual already underwent some abdominal interventions. In fact, she had 2 laparotomies, in the first of which 1 ovary was removed, in the second of which the remaining ovary was wedged. In both cases, the concern was that this individual may in fact harbor an ovarian androgen-producing tumor. Not an unreasonable proposition when you consider the extent of the hirsutism and indeed virilization that this patient experienced. And yet, when this individual's ovaries were examined under the microscope, in no case was there a discrete tumor found. Rather, it turned out we are dealing with a functional disorder, which is characterized by hypertrophy and hyperplasia of the androgen-producing cells of the ovary, which are therefore working overtime, if you will, and are steroidogenically so revved up as to produce this clinical picture clearly attributable to excess male hormone production. In addition to the extensive hirsutism, which is quite apparent, you may also wish to note this lesion here under the patient's armpits and also around her neck. This, of course, is known as acanthosis nigricans, a hyperplastic, hyperkeratotic, hyperpigmented skin lesion, which is commonly, but I should say not exclusively, seen in the context of insulin resistance. It is commonly also seen in the context of neoplasia of a variety of sources, and is a rather striking example in this particular case. This is a close-up view of the axilla in this individual, revealing the, again, very profound nature of the acanthotic lesion in this case, in fact, the verrucous nature of the affliction here. and also gives you yet another opportunity to appreciate the extent of hirsutism that this patient had to cope with. A view from the back gives you yet another opportunity to appreciate the hirsutism, but also affords you with a view of the acanthotic ring around this patient's neck. A close-up view of the same reveals the punctated nature of this lesion, which is very typical, but not limited to the body parts that I just pointed to. You can find these lesions in various degrees of severity, in the popliteal fossa, in the antecubital fossa, and the like, essentially in any bodily crease. And you really want to be on the lookout for those, and not necessarily the extreme variety as shown here, with an eye towards detecting subtle, perhaps clinically inapparent insulin resistance. For those of you who are interested in this particular entity, this is known as the CAN type A form of extreme insulin resistance, the pathophysiology of which has to do with a systemic diminution in the ability of virtually all insulin target tissues to bind insulin. This is a genetic condition which is inherited, usually in a familial pattern. The sister of this particular subject was similarly affected, albeit with different penetrants, which we can get into a little bit later. Suffice it to say that this is a prime example of molecular medicine in action. About 1988, Simeon Taylor from the NIH and his colleagues did in fact uncover the first mutations that were responsible for this condition, specifically mutations which affect the insulin receptor. And indeed, a single amino acid mutation appears to be responsible for this systemic constellation of symptoms, of which hyperandrogenism is but one, and not necessarily the most severe one. Since that time, the NIH group and others have uncovered a whole host of mutations, many of which are listed here, many of which are inactivating, some of which happen to be activating, but for the most part, there are numerous hotspots, if you will, on the insulin receptor gene, which are now well known and are responsible for insulin resistance and a variety of associated maladies. Our geographic proximity to the NIH was really a plus in that many of these patients were referred to us for endocrine and gynecologic care, the diabetic care, and the basic science investigation of the molecular pathology here having been carried out at the NIH over these years. With this example, we have clearly established, as have many others, the association between hyperinsulinemia and hyperandrogenism. But the question remains, as it occurred in 1921, what exactly is the cause and effect relationship here, and is there in fact a direct cause and effect interaction? Is it that the hyperandrogenism is in fact the primary culprit, leading secondarily to insulin resistance and compensatory hyperinsulinemia? Or is it the alternative hypothesis, namely that hyperinsulinemia is the primary problem, with then secondary stimulation of ovarian androgen biosynthesis and the resultant systemic hyperandrogenism? I'd like to explore with you very briefly these two really diametrically opposed hypotheses and try and establish best we can how we think about these issues in 1996. To begin with, let us explore the first hypothesis, namely the possibility that androgens promote an insulin-resistant state and therefore compensatory hyperinsulinemia, and that is in fact the sequence of the pathophysiologic developments. I'm going to argue that in general, subject to some qualifications, the answer to this question is probably a negative one. And I'm going to cite three reasons why that is in fact so. First, representing a fairly large body of evidence out there, it would appear that the experimental induction of rather profound hyperandrogenemia in this case in cycling female rhesus monkeys, was not associated with any obvious alteration of carbohydrate economy as measured by a conventional glucose challenge test before and after a long application of high concentrations of either testosterone or androstenedione. The insulin release curves appear to be virtually superimposable, irrespective of whether or not the animal was untreated or hyperandrogenized on purpose for 6 months on end. In addition, there is a very substantial body of evidence that documents that decreasing the circulating levels of androgens, be it medically or surgically, even by way of oophorectomy, is generally without effect on the insulin-resistant state, suggesting that the insulin-resistant state is in fact intrinsic and not attributable to the hyperandrogenism per se. Finally, and merely as a common sense statement more than anything else, we all recognize that the incidence of insulin resistance is not increased in men despite substantially higher levels of circulating androgens, which would in itself tend to argue in a fairly compelling fashion against the argument that hyperandrogenism is to blame. Therefore, subject to some qualifications which time precludes us from discussing today, I will say for now that androgens don't seem to promote an insulin-resistant state under most circumstances and probably don't account for most of the pathology that you and I may run into. Which leaves us with the alternative hypothesis, namely the possibility that insulin, in fact, stimulates somehow ovarian androgen production, and in so doing, produces systemic hyperandrogenism and consequent hirsutism. Well, to answer this, or to address this hypothesis, we have to first answer the question, is the androgen-producing cell of the ovary, the so-called theca interstitial cell, a site of insulin reception? That is to say, are there specific protein receptors for insulin in the theca interstitial cell which would allow it to begin with to respond to insulin? Because if none were there, of course, the ovary would not even be a target organ of insulin. There is a large body of information now that tends to answer this question in the affirmative. This happens to be a contribution of our own group from the mid-'80s, wherein we demonstrated using what is known as conventional radioligand receptor technology the presence of specific receptors in rat interstitial cells, these being the displacement curves for insulin and for related hormones. This is not limited to the rat, of course. This is a comparable study in the human, demonstrating the presence of specifically bound receptors, insulin-2 receptors, in the stroma of the ovary and in the follicles of the human ovary. These transformed data confirming the same. Moreover, you can actually document transcripts or messenger RNAs corresponding to insulin receptors in the human ovary, this lane labeled O for human ovary, demonstrating the presence of insulin receptor transcripts. And if you use a different technology, so-called in situ hybridization technology, which localizes insulin receptor transcripts in tissue sections, one can demonstrate a very high density at the level of the granulosa cell and a very respectable density at the level of the theca interstitial compartment as well. Thus, using a small representation of a large body of information that's currently out there, I think we can safely conclude that the ovarian androgen-producing cell is in fact a site of insulin reception. Now, while that's all fine and good, it's not so clear that these receptors necessarily convey a functional message. And it is equally important for us to establish whether or not the theca interstitial cell is also a site of insulin action. And to address that possibility, We and others have looked at a number of endpoints of insulin in the context of both the rodent and the human ovary. This is in fact unpublished data that we have worked on in the last 2 years, which evaluate a number of traditional endpoints of insulin, namely glucose uptake into the cells and lactate generation. And interestingly, these findings reveal, counter to expectations, that from a metabolic point of view, the ovary is actually quite blind to insulin and is incapable of responding with increased glucose uptake or by lactate generation. In contrast, a cytokine such as interleukin-1 beta is quite potent in this regard, which renders interleukin a metabolic hormone in the ovary, but labels insulin an endocrine rather than a metabolic principle in the context of the ovary, which is precisely what we're talking about today. Now, the reason this is so is because of the makeup of the so-called glucose transporters of the mammalian ovary, and most importantly, the absence of a key insulin-associated glucose transporter, so-called GLUT4, which is not expressed, in fact, in the human, or for that matter, rat ovary, as shown here. Instead, the ovary expresses GLUT1 and GLUT3, both of which appear to be interleukin-dependent, but are certainly not responding to insulin in a metabolic fashion. So in the ovary, interestingly, insulin is not a metabolic hormone, but rather very much an endocrine principle, a regulator of hormone production, and a variety of other endpoints. Indeed, when you apply insulin, in this case to cultured rat androgen-producing cells, you can demonstrate that HCG or LH will produce marked increments in a representative androgen that is typical of this paradigm. This is in fact a very typical phenomenon which is time-dependent, and you can demonstrate very clearly that the combination of HCG and insulin are in fact much more potent than HCG alone or insulin alone, suggesting a measure of synergy which may explain this huge amplification which we observe, clinically speaking, in the women who are so afflicted. This is, of course, a dose-dependent phenomenon beginning even at the lower, more physiologic range of insulin, extending itself into the pharmacologic range wherein insulin may in fact be acting through other types of receptors. This is again not a rodent phenomenon. This has been clearly demonstrated in the human. I'm drawing your attention to a representative study by Barbieri from 1984, wherein it was clearly shown in minced thecal incubates that the addition of insulin to LH, labeled LI, will result in a marked and in fact synergistic stimulation of androstenedione production as compared with the impact of insulin alone, labeled I, or LH alone, labeled L, all of those contrasting with control untreated counterparts. Clearly then, in the mammalian ovary, be it rodent, human, pig, and other circumstances, it would appear that insulin enhances LH-supported ovarian androgen production by the androgen-producing cell of the respective ovaries. While this is all nice and good, you could well legitimately raise the question at this point, how do all these in vitro observations have any bearing on the human condition and on the syndrome that I shared with you at the outset of this presentation? And indeed, to make the point stick, some sort of in vivo documentation would have to be provided. This is not an easy matter, of course, because we are moving from the realm of in vitro animal experimentation to a human paradigm. And yet, this is where it's at, and this is, of course, very important. One effort to get at this, representing again a large body of information which time precludes us from covering this morning, has to do with the question, what happens if you produce acute hyperinsulinemia what happens to androgen economy in particular? In other words, if it's really true that insulin is the culprit and that it stimulates androgen biosynthesis, can you in fact reproduce this in vivo by producing acute hyperinsulinemia and then measuring circulating androgens and other key reproductive hormones? This particular contribution by Nestler and Associates from 1987 is perhaps one of the best in this regard. This approach, which like many others, relied on what's known as the hyperinsulinemic euglycemic clamp technique, allows one to achieve pharmacologic hyperinsulinemia for a predetermined period of time, in this case for 16 hours, without pushing this patient into a hypoglycemic crisis by virtue of concurrent administration of glucose, which when it's all said and done, maintains this patient in a fairly euglycemic range. Thus you have an artificial circumstance whereby you have very high levels of insulin for about 16 hours without in fact having to worry about the circulating levels of glucose. Armed with this paradigm, Nestler ended up measuring some key reproductive hormones such as LH, testosterone, progesterone, and the adrenoandrogen dehydroepiandrosterone sulfate. And you will note that really, with the exception of a downward trend which has since been reproduced for DHEAS, there are no obvious marked changes in this acute experimental paradigm, suggesting that at least in the acute state, the elevation of insulin to pharmacologic levels does not really produce any major changes in the circulating levels of testosterone or in LH, a fact which was verified by numerous investigators thereafter. Thus, the acute paradigm appears to be without significant effect on circulating levels of either LH or testosterone. What then can we do to demonstrate in the chronic, perhaps, state an impact of insulin on ovarian hyperandrogenemia? We can speculate that supraphysiologic concentrations of insulin could perhaps enhance ovarian androgen production under chronic rather than acute circumstances, since the acute circumstance just doesn't seem to do it as best as we can ascertain. Well, that's not a very simple issue to address. Certainly, chronic hyperinsulinemic euglycemic clamp techniques are not exactly a practical proposition. Women are not exactly lining up to be hooked up to an insulin and glucose infusion for days on end, or for that matter, weeks on end. And so we are left with naturally occurring examples of disease states that are characterized by chronic hyperinsulinemia secondary to insulin resistance and attendant hyperandrogenism. And when you think about those in the context of reproductive medicine, the two that come to mind are, of course, PCO and hypertrichosis, which brings us to the main topic, if you will, of our discussion today, namely hyperinsulinemic hyperandrogenism in the context of one particular entity that our specialty is interested in, and that is PCO. In the interest of time, I will not be discussing hypertrichosis, an entity that Dr. Nagamani has been very interested in, which in many ways could be viewed as an extreme variant, if you will, of PCO, although that is by no means a categorical statement. But in many ways, it would seem that hypertrichosis is merely an exaggeration of the signs and symptoms that we run into in the PCO subject. PCO is, of course, well familiar to all of you, but at the same time, we recognize that what we, in fact, can agree on with respect to the putative features of PCO remains somewhat controversial. We can probably all agree that PCO is compatible with polycystic ovaries, hypersecretion of LH, and probably ovarian hyperresponsiveness to exogenously provided gonadotropins. But the consensus often breaks down when one gets into hyperandrogenism, ovulatory dysfunction, and to some degree insulin resistance. In other words, not everybody agrees that PCO is inevitably linked to hirsutism, to anovulation, or for that matter, to insulin resistance. I do not wish today to address this controversy or to even begin to discuss it. Instead, I wish to spend the remainder of the time on the insulin resistance as it characterizes PCO and to share with you some of the implications this may have on the women we care for and on their health. The individual that probably put this connection on the map is James Givens, an Alabama born and bred endocrinologist who was Vanderbilt and Tufts trained, but who spent most of his professional career in Memphis, Tennessee, and who established probably for the first time the association between insulin resistance and PCO. He has had a distinguished career elucidating this connection. He's still with us, although he's not quite as well. It was his suggestion and his observations that have led to the general, and I would say at this point somewhat loose hypothesis still, that PCO in the final analysis may in fact be comprised of two major pathologies, if you will, genes, although that remains to be seen, one of which coding for or being responsible for the polycystic phenotype, the ovarian polycystic phenotype, which we can now nicely demonstrate sonographically speaking, and this prime pathology at the level of carbohydrate economy characterized by insulin resistance. Those two together conspiring to provide what you and I recognize as PCO with all its attendant features. It was in fact the hope of Dr. Givens and many others that the insulin connection will ultimately allow us to decipher the pathophysiology of PCO. But those hopes, for the most part, at least to date, have not materialized. And although we all recognize that insulin resistance may be an important feature in some, maybe not all patients with PCO, we really don't have a good sense of what the significance of that connection is to the very pathophysiology of the disease, and in what way are the two really related pathophysiologically speaking, the phenomena being no longer an issue for discussion. There's a whole host of in vivo observations that I will trace very quickly for you that document the association that Dr. Givens first established. As shown in this early contribution by Lobo, you can demonstrate an increase in the fasting levels of insulin in patients with hirsutism and PCO, somewhat lesser degrees of affliction being noted in non-hirsute PCO and in so-called plain unovulators who have a non-PCO type of chronic anovulatory syndrome. But more importantly, you can subject the women in question to dynamic stimulation by exposing them to a conventional glucose challenge test and by measuring not so much the circulating levels of glucose, but the circulating levels of insulin. Indeed, as Dr. Chang first demonstrated, at least in our specialty, this time for individuals who were age-matched and weight-matched, it is quite apparent that despite seemingly comparable and superimposable glucose absorption curves in PCO versus normal counterparts, the insulin release curve is very different in PCO subjects as compared with normally cycling controls, indicating, and this really is the sine qua non of insulin resistance, that to compensate, these individuals have to engage in marked outpouring of insulin to accomplish this seemingly normal glucose absorption curve, but only at the expense of this huge outpouring of insulin from the pancreas, which is attempting to compensate for an underlying insulin resistance. This is, of course, the only way to document in a practical sense insulin resistance once you get past the fasting sugar and perhaps past the fasting insulin concentrations. If you are in a research setting, of course, you could subject some of these women to 24-hour monitoring, and there's no question that over time you will demonstrate a consistent increase in the circulating levels of insulin in these women as compared with normally cycling controls. There is a stoichiometric relationship to C-peptide, which is released along with insulin, the glucose concentrations being, for the most part, much closer to each other, although you can tell that there is a difference even in the fasting state. Clearly then, in the typical PCO subject, if you will, independent seemingly of weight, there is, or there seems to be, intrinsic insulin resistance which is manifesting itself very clearly. Whether this is true for all PCO subjects remains a question and is still the subject of controversy. Quite possibly, in those patients who are presumably normal or negative, we haven't looked hard enough, or we haven't employed techniques that are sensitive enough. The glucose challenge test is clearly not the most sensitive way of uncovering insulin resistance, but it is impractical for the most part to apply the more sensitive technology to large populations of women. Consequently, those who are so-called negative may or may not be truly negative, may just suffer from a very mild affliction that we simply have not brought to light. There are some in vitro observations that tend to complement these in vivo studies. For example, the ability of insulin to effect glucose transport into adipocytes is markedly reduced in the patients in question as compared with normally cycling controls, although if you use high enough concentrations in vitro, you eventually make up for this relative resistance. This appears to be due, at least in part, to a decrease in the abundance of the insulin-associated glucose transporter number 4, so-called GLUT4, which appears to be across the board diminished in PCO subjects, as you can see here, whether or not they are obese or lean as compared to normally cycling counterparts. Thus, there are clear-cut in vitro correlates to this insulin resistance, which appears to hold true. At this point, you might ask, what in fact is the mechanism responsible for insulin resistance in these women? And as is true for any insulin-resistant state, there are three possibilities. The less likely possibility is that these women with PCO have abnormal insulin receptors, not unlike the woman I showed you at the very outset of my presentation. Circulating anti-insulin receptor antibodies have been described in some patients. That tends to be an acquired autoimmune phenomenon which occurs later in life. And finally, there is the possibility that the resistance lies beyond the insulin receptor, inside the cell, somewhere along the signal transduction cascade, which conveys the insulin signal to the inside of the cell all the way to the genomic structures. In scanning the literature, one finds that the answer to these questions are still incomplete and in fact somewhat confusing. Nobody really has been able to demonstrate diminished insulin receptor binding in PCO, and for that matter, insulin receptor antibodies. But there are several reports now that are fairly convincing, reporting some post-receptor defects, the details of which I will not discuss today. The bias that many investigators have, and I share that opinion, is that the problem in insulin resistance in PCO is in fact post-receptor in nature and lies in any one of these many proteins that serve as way stations in the cascade that conveys the impact of insulin at the cell surface level and transmits the signal through these various intermediaries to the genomic elements. Which of these proteins is in fact defective and why remains, of course, to be demonstrated. But that, to me, is fertile ground for investigation, and it is very likely that one or more of these connectors in some way are negatively affected in the context of PCO, something that we will hopefully be able to uncover in the next 10 or 15 years. Before I close, I should probably point out that there are some other issues that contribute to the hyperandrogenism seen in these patients. One little appreciated phenomenon is the fact that insulin is a potent suppressor of the liver-derived protein sex hormone binding globulin, or SHBG, which of course has the potential to bind circulating testosterone. The more SHBG you have, the more testosterone is bound. The less you have, the more of it is free and bioavailable for consumption by tissues. Insulin appears to decrease the circulating levels of SHBG, as shown in this regression analysis. And in vitro, in cultures of hepatocytes, insulin clearly is shown to diminish the overall elaboration of SHBG as compared with untreated controls, and obviously is far inferior in that respect to estradiol, which is a known stimulator of SHBG in this same setting. Thus, a small complicating feature, if you will, or an additional component in this equation is the overall economy of SHBG, which appears to be altered in an unfavorable fashion in the context of the hyperinsulinemic PCO subject. In closing, these observations and many others, which we obviously will not be in a position to review today, would argue that the normal, as well as the PCO ovary, is a site of insulin reception and action. The polycystic ovary syndrome probably is commonly, perhaps not invariably, associated with insulin resistance. Hyperinsulinemic hyperandrogenism is attributable to the stimulation of the ovarian androgen-producing cell, presumably by the combined action of LH and insulin, which are acting in concert and in synergy to effect this outcome. I don't for a moment, though, wish to leave you with the sense that we have sorted all of this out and that we are all comfortable with where we are. Far from it. This is truly just the beginning. I'm not just referring to the still unresolved molecular nature of the defect that is responsible for insulin resistance in these patients. I'm referring to a whole host of issues that remains clearly unresolved. This is merely a sampling of perhaps some of the key ones. For example, we still don't know, as I pointed out earlier, whether or not insulin resistance is in some way central to the pathophysiology of PCO. Is this an epiphenomenon, or is this centrally relevant to the pathophysiology of the chronic anovulation, the ovarian sonographic phenotype, the hyperresponsiveness to gonadotropins, etc., all the features which make up the so-called PCO syndrome? What in fact are the cellular and molecular mechanisms underlying insulin resistance in PCO? What is the post-receptor element that seems to have gone awry, if that is in fact the case? And last but certainly not least, how can insulin act at the level of the polycystic or hypothyrotic ovary in the face of otherwise systemic insulin resistance? In other words, how can we argue that there is systemic insulin resistance that in fact manifests itself with carbohydrate intolerance, and at the same time argue that insulin is overactive at the level of the ovary, working overtime to stimulate ovarian androgen biosynthesis? How is it that the ovary is spared, so to speak, this systemic resistance, and is it indeed? This is an intrinsic paradox that has to be gotten around, and at this point, although several hypotheses have been put forth to account for it, none of them is fully satisfactory. Consequently, while we are still grappling with this whole constellation of findings, we are making progress, but by no means can we say that we have gotten where we want to go. Ladies and gentlemen, thank you very much again for putting up with me this early in the morning. There being any questions, I would be delighted to respond. Thank you very much again.